Okay, so chapter 4 is called Anxiety, Trauma, and Stress-Related and Compulsive, Obsessive Compulsive and Related Disorders. So first, we need to talk about sort of this broad category of anxiety disorders. So when it comes to anxiety, it is created because of future-oriented mood states, like the anticipation of danger or misfortune, or what a person thinks might happen causes them to feel tension and to experience negative emotions. Oftentimes, when people experience anxiety, they might choose not to pursue situations that make them fearful or where they think anxiety provoking things might occur. But it's important for us to remember that anxiety and fear can be normal emotional states. It's okay to be nervous or scared about something, but when it becomes anxiety and it prevents you from achieving the things you need to achieve, then that's when it can become problematic. So, fear, when somebody fears something, that is a present oriented mood state. So it's happening at the moment. That's the activation of your fight or flight response because there's immediate threat or danger in front of you. It involves some type of activation of your sympathetic nervous system. So it might mean that you are alarmed and sweating and your heart is racing. Something is happening to you physiologically. And there is a strong avoidance or escapist tendency that you may have, like, I got to get myself out of this situation. And then, of course, also negative affect. So, when it comes to anxiety disorders, there are a few characteristics that make up what an anxiety disorder is. Anxiety disorders are pervasive and persistent, involving worrying or anxiety and fear about what could happen. It involves an intense or excessive need to avoid or escape a situation, and it can cause clinically significant distress and impairment. A panic attack is sometimes what can happen to someone who experiences panic disorder. This is when they might have an abrupt experience of intense fear and they have those physiological symptoms, maybe heart palpitations, chest pain, dizziness, sweating. And then they also have something going on cognitively. So there's something in their head that's making them feel intense fear. So maybe it's a fear of losing control or dying or going crazy, and they're telling themselves, I don't know what's happening. I'm going to die. I'm losing my mind. I'm going crazy. And there are two different types of panic attacks that can occur, and those are expected panic attacks, and then, of course, unexpected ones. So, if we think about the DSM and what the DSM says about panic attacks, here are some of the symptoms that you can expect when a panic attack occurs. I'm not going to read through all of the symptoms as we talk about all of the DSM criteria. I just want you guys to see, because I'm not asking that you purchase a DSM. That can be very expensive, but I do want you to see what the symptoms of a disorder look like. So, as the DSM says, it will be an abrupt surge of intense fear within minutes, where at least 4 of these items, these 8 items that are listed there, must occur. So, not all of them, but at least 4 of them in order for it to be classified as a panic attack. And here's 5 more criteria that can also exist for a panic attack, according to the DSM. So, in your book, one of the figures that I thought was a good one to talk about is the anxiety, fear, and panic figure 4.1, because this can show you, okay, what does anxiety look like? It's all of these things. What does fear look like? It's all of these things. And that is what can lead to a panic attack. So, when it comes to our experiences of anxiety, there are a few things biologically that could happen that could make us more susceptible to anxiety and panic. So we could have some genetic vulnerabilities. You're more likely to be anxious if you have a family history of anxiety. Anxiety and brain circuits also have to do with some things that are going on in your brain, like depleted levels of GABA. Those can be associated with more anxiety. Deficits in norepinephrine and serotonin can also be associated with great anxiety. And then, whatever your fight or flight system, your behavioral inhibition system, or your limbic system or septo-hippocampus systems are activated, it can lead to anxiety or panic. Many times, there are also some psychological contributions that could impact your experiences of anxiety, such as things that happened to you during your early childhood, like experiences with uncontrollability and unpredictability, depending on if you grew up in an environment where things were just uncertain. Different stressful life events can also trigger a person's vulnerabilities to anxiety. From a behavioral and cognitive standpoint, um, anxiety is involves conditioning and cognitive explanation. So what's going on to you in your head? Anxiety and fear can also be viewed from a behavioral standpoint as a learned response. This is what you've seen, and this is what you've learned to do. This is what you've been rewarded from doing. And then also, of course, from a cognitive standpoint, catastrophic thinking and negative appraisals could also play a role in the development of anxiety. So, if we think about an integrated approach to how we can look at anxiety, we can think of the triple vulnerability model, which says that we've got biological vulnerabilities, we've got psychological vulnerabilities that are both generalized, but then we also have some specific psychological vulnerabilities as well. So, a biological vulnerability is going to be some type of thing that you've inherited that's heritable and contributes to your negative affect. Um, it's the difference between somebody who sees the glass half empty versus half full. Being irritable and driven, you could be biologically vulnerable to those characteristics. When it comes to those psychological vulnerabilities that are very specific, these are going to be the physical sensations that could be potentially dangerous. So, do you have anxiety about your health? Are you engaging in non-clinical panic situations? And then the generalized psychological vulnerabilities could be the sense that events are uncontrollable or unpredictable, and as a result, you tend to go towards those things or lack confidence, have low self-esteem, and an inability to cope in situations where things are uncontrollable or unpredictable. Comorbidity happens when a person has more than one psychological diagnosis or disorder that could be happening at the same time. It is very common for those who suffer from anxiety disorders to also have some other type of comorbid disorder. Major depression is the most common comorbid disorder that is often diagnosed with anxiety, and about half of patients um, will have two or more secondary diagnoses as well. And the implications for that tells us that these are common factors that can create and maintain disorders, and that there's also a relationship that exists between anxiety and depression. Doesn't mean that everybody who's depressed is also anxious, or everybody who's anxious is also depressed, but we have found that there tends to be some commonality between the two. So, if we think about anxiety disorders overall, here are a list of the anxiety disorders that are listed in the DSM. Again, I'm not going to read this to you, but these are the specific anxiety disorders we'll discuss. Starting with generalized anxiety disorder. People with generalized anxiety disorder are your chronic worriers. I call them my worry warts, because these are people who generalizing their anxiety to everything. They worry about any and everything. This is excessive, uncontrollable, anxious apprehension and worry in various multiple areas of their life. It has to persist for at least 6 or more months for it to be diagnosed. And it also has to be accompanied by associated symptoms of some type of physiological arousal. Here are, based on the DSM, some common criteria for GAD. Once again, I'm not going to read over these specifics, but I want to show it to you because we're not actually purchasing a DSM. But what I just told you on the other slide is the most important things to remember about the disorder. But here are some criteria that would get someone diagnosed with generalized anxiety disorder. When it comes to statistics related to the disorder, generalized anxiety disorder, or GAD, affects about 3% of the general population. Females tend to outnumber males 2-to-1 when it comes to diagnosis. If you think about it, think about some contributing factors that might play a role in why females are developing more generalized anxiety disorder than males. The onset of the disorder is often insidious. It can begin in early adulthood and just persist throughout the life. It's very prevalent among the elderly as well, and we know that generalized anxiety also tends to run in families for some of those reasons we mentioned earlier. Some associated features of GAD is those autonomic restrictors and sensitivity to threats, less physiological response to stress than people with other anxiety disorders. So even though there is physiological arousal, it's not the same way it would be with, say, panic disorder. When it comes to treating generalized anxiety disorder, treatment is generally very weak. We can have clients engage in therapy, such as cognitive behavioral therapy. We can also provide psychotropic medications, such as benzodiazepines, even antidepressants, medication therapy, and combined treatments for therapy and medication can also help with the disorder. But it's one of those things that, person has to learn coping skills and then also actively practice those things for them to work. Here's an integrative model of generalized anxiety disorder that's mentioned in your textbook, and I thought it would be a good idea for you to see figure 4.3 so that you can see kind of the generalized biological vulnerabilities, those psychological vulnerabilities, and how they kind of work together to create the disorder. The next disorder I'd like to discuss is panic disorder, which involves the experience of unexpected panic attacks, which are these sort of false alarms that occur in the body that can tell a person, I got to get out of this situation. It occurs when a person develops anxiety, worry, and fear about having another attack. Sometimes when a person has suffered from panic disorder, they might also develop agoraphobia, and they may not want to leave their home or their safe haven because of a fear of developing another panic attack. So here again are the criteria that are in the DSM for panic disorder. I'm not going to read over these specific criteria, but I want you to see what they are since you don't have a DSM. And agoraphobia is the fear of being in a place where you feel like you might lose control or not be able to escape and get help. And really, it's the fear of having another panic attack in those types of situations. So oftentimes, panic and agoraphobia can occur together, and they can also occur independently of each other. So someone with panic disorder, say they went into the grocery store and got to the door and said, I don't think I can do this. I'm afraid that I'm not going to survive. I'm afraid that something bad is terrible is going to happen. And they turn around and they leave the grocery store. They might go home and they might feel like they can't ever go back to the grocery store. So they might start ordering their groceries and things like that. And perhaps in that case, they've developed some agoraphobia. They don't want to go out in public or be in a place where they feel like it would be difficult to escape or get out of. Here are the DSM criteria for agoraphobia. It's the fear of sort of being in places where you lose control, being in public. Here's some other criteria. Once again, I'm not going to read those, but just want you to see what the DSM says about the disorder, so you have a good understanding of it. Now let's continue discussing panic disorder. So if we look at some facts and statistics regarding panic disorder, it generally affects about 2.7% of the general population. The onset can be very acute, oftentimes between 20 and 24 years of age. 66% of individuals with agoraphobia also are females. There are some cultural implications for the development of panic disorder as well, such as panic attacks being interpreted differently across various cultures, because in some cultures, it may not be seen as psychological, and in other cultures, it might be something that's psychological. Some risk factors for developing panic disorder are higher levels of emotional reactivity to stressors. So, if something bad happens, if your immediate response is, I don't know what to do, that could be one of those indicators of panic disorder. Higher likelihood of having physical alarm reactions in response to a stress, sweating, those, heart palpitations, things like that, those physiological changes, and a tendency to believe that bodily sensations are dangerous or associated with catastrophic outcomes. Again, that has to do with your thinking. So here's another chart from your textbook that I thought was worth showing and discussing, and that is figure 4.5, because it shows us some different causes of panic disorder, and we can look at those generalized psychological vulnerabilities, those biological factors, and how they can all sort of create the development of a disorder. And when it comes to treating panic disorders, we can look at different types of associated features. So, nocturnal panic attacks that occur during non-REM sleep, or interoceptive avoidance. And then we can sort of think about, okay, what's going to be the most effective way to treat this? Oftentimes, it's medication, such as benzodiazepines, sometimes SSRIs. Relapse rates are high following medication discontinuation. So it's one of those things that if a person does decide to take medications, they'll need to stay on those medications so that the panic attacks don't come back in great quantity. And then we also know that cognitive behavioral therapy is highly effective for the treatment of panic disorder. So remember, a large feature of panic attacks or a panic disorder is the idea of something bad happening. So being able to work on those thoughts can greatly impact the disorder. There's also something called panic control treatment, or PCT, which is a specific type of CBT for panic disorder, which combines purposely triggering panic sensations to build tolerance. So I'm going to put the person in a situation where they are panicking and teach them how to handle that situation. And then we also know that psychological combined treatments can be very effective. So cognitive behavioral therapy with medication, or with something else could also be helpful. But we know that long-term outcomes are best with cognitive behavioral therapy alone. So because using medications can cause the disorder to come back, and discontinuing the medication can cause it to come back very strong, oftentimes people maybe don't need the medication for an anxiety disorder. As long as they learn the coping skills and they learn ways to manage the situations and they're in and their thoughts, they tend to have better outcomes. So if you look at chart 4.6, you can look at the percentage of patients who relapse within 6 months with panic attacks, whether or not they had cognitive behavioral therapy and medication intervention, or whether or not they had medication alone, or cognitive behavioral therapy alone, or cognitive behavioral therapy and some type of behavioral intervention as well. And we can see that the percentage who relapsed with cognitive behavioral therapy alone was much lower than those who took medications. Another type of anxiety disorder is a specific phobia. And a specific phobia involves, again, irrational fears to a situation or an object. The person might go through great lengths to avoid an object. They recognize that the fear and avoidance are unreasonable. Although they recognize that, it still doesn't cause them to stop fearing the situation or the object. And it can markedly interfere with one's ability to function. Because if you're afraid of a situation of an object, so you avoid them, you probably won't get to where you need to be. Here are the DSM criteria for a specific phobia. Once again, I'm not going to read that to you. I just want you to see what the DSM says. And here are those remaining criteria. So when it comes to facts and statistics, once again, females are overrepresented. I really want you to be thinking about why females might have more instances of anxiety disorder than males. It generally affects specific phobias, about 12.5% of the general population. So a much larger number of people have a specific phobia. The course of phobias tends to be chronic. Once people have that phobia of, I don't know, spiders or blood, they tend to have it for probably their entire life. Specific phobias are one of the most common psychological disorders in the United States. And there's a 4-to-1 ratio between females and males, and that is consistent around other parts of the world also. Here are the common specific phobias: animals, natural environments, situations, blood injection injury. Perhaps some of you have some of these common specific phobias. Here is figure 4.7 that's in your textbook that kind of drills down to exactly how a specific phobia, what that looks like when it comes to those biological vulnerabilities, those psychological vulnerabilities. And when it comes to causes of phobias, they're usually created by direct experience. Also, some biological and evolutionary vulnerability might tend to run in families. But again, traumatic conditioning, if you've watched other people in your family also fear those same things, you might also fear them. And then also preparedness, like how prepared are you for a situation to occur? Might create some fear if it's unexpected. Some different psychological treatments for specific phobias. Once again, cognitive behavioral therapy has been proven to be highly effective because it's all about changing the way you think in relation to your behaviors. Also, cultural factors can play a role because certain objects are feared more in different cultures. The next disorder I'd like to discuss is social anxiety disorder. This involves extreme fear or discomfort in social or performance situations. It oftentimes interferes with a person's ability to function. They might avoid social situations or endure them with great distress because they really don't want to be there. And there's also a performance-only subtype, which tells us that anxiety might only occur in performance situations like public speaking, without anxiety in other everyday interactions. Separation anxiety is characterized by unrealistic and persistent worry that something will happen to yourself or a loved one when you're apart, as well as anxiety about leaving loved ones. About 4% of children meet the criteria for separation anxiety and 6% of adults. So it's natural for children to experience some separation anxiety as they're starting to grow and develop and mature, but for it to be persistent where the child can't go to school because they are worried, that's about 4% of children. When it comes to social anxiety disorder, the facts and statistics tell us that about 12% of the general population and 6% in a 1-year period experience social anxiety. Once again, it's more prevalent in females than males. It's second only to specific phobias when it comes to the highest rated anxiety disorder. Onset is often during adolescence, and the peak age of onset is generally about 13. So if we think about puberty and when it strikes and, sort of that adolescent egocentrism, I think everybody's watching me. So now I want to avoid social situations. Once again, here are those DSM criteria for social anxiety disorder or social phobia. Here are the rest of those criteria. And here's that figure 4.8 that's listed in your textbook that can kind of drill down and help you see that when you have the generalized psychological vulnerability and those biological vulnerabilities as well, it can create stress, which can also lead to that social anxiety disorder. When it comes to causes and treatments of social anxiety, we have to look at biological and evolutionary vulnerability, which is, over time, was it adaptive to fear rejection, and how did my species evolve over time? Similar learning pathways as specific phobias. For psychological treatment, of course, we know that cognitive behavioral therapy and the different types of cognitive behavioral therapies are most effective. Even some group treatment can also be effective. Sometimes people with social anxiety might also take medication, SSRIs, beta blockers, benzodiazepines, and those relapse rates are kind of mixed with and without medication discontinuation. Another disorder I'd like to discuss is selective mutism, which in the DSM-5 was grouped in with anxiety disorder. This is a rare childhood disorder that's characterized by a lack of speech. This most often occurs for more than 1 month and cannot be limited to the first month of school, because it might be normal for a child not to talk as much in school because they're in a different social setting. There's a high comorbidity with social anxiety disorders and selective mutism. And we know that treatment for this disorder is primarily cognitive behavioral therapy, just as it is with social anxiety disorder. When it comes to the trauma and stress related disorders, this is a new category that was put in the DSM. We used to think of PTSD as a anxiety disorder, but now it's got its own category with other trauma and stress related disorders. And you might think about, well, why in society might that be the case? What's happened, from early 2000s to 2013 that led to this new category of disorders? These disorders include things like PTSD and acute stress disorder, as well as adjustment and attachment disorders. So first, we'll discuss post-traumatic stress disorder, which is trauma exposure and response. It involves the re-experiencing of a trauma, trying to avoid situations that could lead to trauma, emotional numbing, and interpersonal problems. Interference with ability to function on a day-to-day basis. And PTSD is often diagnosed when reaction persists for 1 month or more. Before 1 month, we're going to think of it as acute stress, and that can be seen as very normal. But one thing I do want to say about post-traumatic stress disorder is oftentimes we tend to associate it with combat or the military, but anybody who's experienced a traumatic event that they continue to re-experience could have PTSD. It could be a sexual assault. It could be a car accident. It could be a natural disaster. And just because two people might go through the same experience doesn't mean their interpretation, the way they view it, is the same. So one person could develop PTSD where the other person may not. Here are some diagnostic criteria according to the DSM for PTSD. Here are the rest of those cluster B criteria. And here are those cluster C criteria. And here are those D criteria as well. And lastly, E criteria. So those are all the 5 different criteria for the development of post-traumatic stress disorder. When it comes to statistics, combat and sexual assault victims are the most common reporters of post-traumatic stress disorder, but they don't have to be the only ones. Approximately 7% of people experience PTSD at some point in their life, half of that in the past year. There's lower than expected prevalence rates in trauma survivors. Many trauma survivors don't develop PTSD, and there could be a number of factors that contribute to that as well. Acute PTSD may be diagnosed 1 to 3 months post trauma. Chronic is diagnosed after 3 months post trauma. Delayed onset occurs if that diagnosis occurs 6 months or more past the trauma. And then acute stress disorder, of course, is that precursor to PTSD. It occurs right after a trauma for up to 30 days when something traumatic has occurred. So, when it comes to the causes of PTSD, it could be due to the intensity of the trauma and how a person reacts to it. It could be based on learning and observation from others. There could be biological vulnerabilities, uncontrollability, and unpredictability, often associated with those anxiety disorders, and social support and post trauma um, can reduce the risk. So we know that people who have good social support are less likely to develop PTSD. And here's once again for point 9, sort of that chart that kind of tells you how those generalized vulnerabilities can occur and lead to the trauma. When it comes to treating PTSD, cognitive behavioral therapy, again, is one of the most effective ways to treat it. It could include exposure to the trauma. It could also include process understanding and challenging maladaptive beliefs about the world. Medication is sometimes used for PTSD, most commonly SSRIs. Those medications can be effective against anxiety and panic. Sometimes people take sleep medications as well to help them sleep at night. Next, let's talk about adjustment disorders. This occurs when a person is anxious or depressed because of a change in life or some type of life stressor. This is much milder than PTSD, an acute stress disorder, and it is going to occur whenever somebody has experienced some type of life change. But it creates clinically significant distress or impairment. Attachment disorders oftentimes occur in children, and this is disturbed and developmentally inappropriate behaviors in children. The child might be unable or unwilling to form normal attachment relationships with their caring adults, and this can often occur as a result of inadequate or neglectful care in early childhood. We oftentimes see attachment disorders happen for children who've been in foster care or children who have not had really good, strong role models. So, one such disorder is reactive attachment disorder, and this occurs when children are emotionally abnormally withdrawn and inhibited. They can be less receptive to support from their caregivers. There's also disinhibited social engagement disorder, which involves low inhibition in children. So, these are children who will go up to relative strangers and talk to them and want them to love them. Um, they don't have that stranger danger that they need because they're just trying to attach to whoever they can. And lastly, we have some obsessive compulsive and related disorders. This is also a new category in the DSM-5, and this is where we grouped a few obsessive compulsive disorders with things such as hoarding disorder, body dysmorphia, trichotillomania, and excoriation. So all of these disorders are also a new category. They felt the need to add it in 2013. It wasn't there in the DSM-4. So first, let's talk about obsessive compulsive disorder. This involves obsessions, which are kind of intrusive thoughts that interfere with a person's functioning. Compulsions, which are behaviors or actions that happen as a result of those obsessions. And it becomes a vicious cycle of obsessions and compulsions. Cleaning and washing and checking are some of the most common obsessions or compulsions people might engage in. Obsessions, again, are those recurring thoughts, and this is your diagnostic criteria for obsessions here under category A. And compulsions are listed here, those behaviors people engage in. And then here's kind of a summary of what obsessive compulsive disorders might look like. When we think about causes, only about 2% of the general population has true obsessive compulsive disorder, although I hear people talk about having it much more than they actually do. It actually is equal when it comes to the genders. There's a similar incidence and presentation across cultures, so it's not like it affects some people more than others. The onset is typically also in early adolescence or young adulthood, and it tends to be chronic. When it comes to causes of obsessive compulsive disorder, it kind of parallels with other anxiety disorder, those early life experiences, um, thoughts that are negatively impacting functioning. Here is figure 4.10, and it tells us those vulnerabilities as well that can lead to disorder. When it comes to treating obsessive compulsive disorder, we can have medications such as SSRIs, but relapse is common when medication discontinuation occurs. Some people also have psychosurgery, but that's only used in extreme cases and it's not really always recommended. When it comes to psychological treatments, we know that cognitive behavioral therapy is once again most effective. It can involve some exposure to those anxiety provoking situations and processing and working through those thoughts. And research has also told us that, this is another situation, just as with anxiety disorder, you can combine it with medications, but it won't be any better than CBT alone. Body dysmorphic disorder has some criteria here as well, according to the DSM. This is a new disorder in the DSM, which was first introduced in 2013. Can you think about a reason why body dysmorphic disorder might exist? It involves sort of preoccupation with some type of flaw in your physical appearance that other people may not notice. It's far more common than we previously thought. It generally affects about 1 to 2% of the general population. 4 to 28% of college students meet the criteria for this disorder at some point. It can also be seen equally in males and females. Many people remain single and seek out plastic surgeons. Its course can be long term. And this is one of those disorders that honestly, I feel like social media plays a big role in. We don't really know, and we can't say for certain what causes this disorder. It does tend to run in families. So there's a lot of similarities between OCD, but I must say, social media hasn't made body dysmorphia any better. So when it comes to treating body dysmorphia, it's going to be the same as many of the treatments for obsessive compulsive disorder. So cognitive behavioral therapy, exposure to anxiety, medications that work for OCD might provide some relief, but it's not going to make it go away. About 76% of people with body dysmorphia have sought plastic surgery. 66% were receiving it when a study was done about people with body dysmorphia. 8 to 25% of them request plastic surgery. 8 to 25% of people who request it may have body dysmorphia. That might help worsen the condition. It's probably not going to help. That's why oftentimes we see people pursuing multiple plastic surgeries after the first one. So, in summary, anxiety and related disorders occur when natural and adaptive processes such as anxiety, fear, and panic become disproportionate to the environment. These disorders can result from biological vulnerabilities, psychological vulnerabilities that are both generalized, or some specific psychological vulnerabilities. Hoarding disorder is also considered a type of obsessive compulsive disorder. It involves excessively collecting and keeping items regardless of their value, even if it's something that's like an empty envelope. It's this kind of fear of getting rid of something that you might need later. It can cause clinically significant distress or impairment, oftentimes houses that are too cluttered to live in, arguments with family members. And then we also have hair pulling disorder, trichotillomania, and skin picking disorder, which is excoriation. Trick, um, Trichotillomania involves the urge to pull one's hair from anywhere on the body, and it can lead to noticeable scalp and eyebrow and arm issues. And excoriation is the repetitive and compulsive picking of the skin, which can lead to tissue damage. There's about a 1 to 5% prevalence rate of excoriation, and these are sort of behavioral habits, and reversal treatment is often effective for this. So this is something that's behavioral that can be treated using behavioral therapy. When it comes to body dysmorphic disorder, that is the preoccupation with some type of imagined deficit in appearance, as I told you before. Um, it's oftentimes just slight to others, but can be clinically distressing or um, lead to these compulsive behaviors. So, when it comes to anxiety disorder, here are some of the disorders that we discussed. And here's some other disorders we discussed related to traumas. And here are some disorders we discussed related to obsessive compulsive disorders. So, the most common effective treatment for most anxiety disorders, as we talked about, is cognitive behavioral therapy. Medication could also be helpful, but it also can lead to relapse upon ending the medication. So, I know that was a long lecture, but I really wanted to make sure I went through all of those criteria for those disorders with you. And I hope this helps with your understanding of the content.